I did not have a case that was submitted for us to go over today. If anybody has anything that they would like to discuss or a topic or something that's recently happened that you want to get some feedback from, you guys are welcome to take a few minutes and do that. Anyone have anything that's stuck out to them? All right. If you guys think of anything during the didactic presentation, you can bring it up after. Feel free to ask questions as we go along. We have, is it Brundage?
Brundage.
Okay, I'm just,
I go by all variations of it. That's
okay. Let me bring your slideshow. Oh, we have two people.
okay, ready?
All right, ready whenever you are.
Okay, I'm Sandy Brundage. I'm a second-year resident in the occupational medicine program at WVU. My background is in emergency medicine and forensic psychology, two areas which regularly deal with workplace violence. My goal for this presentation is to give an overview of how widespread the problem is, invite everyone to share any personal experiences and concerns, and to talk about what we can do to mitigate violence in the healthcare workplace. Next slide, please. So this slide looks busy, and that's on purpose. This is really the tip of the iceberg as far as fatal assaults in the United States in both inpatient and outpatient settings. And these are only the ones that made the news. So when working on this presentation the other week, I wanted to add a couple more recent incidences. And of course, there were too many to choose from within the past year. And note that this does not even begin to show the number of non-shooting attacks or non-physical assaults. And just some of the highlights, 2018, there was a man who shot and killed his ex-fiancée in the parking lot of a Chicago hospital. 2023, 5 people were shot at an Atlanta outpatient clinic. 2024, a patient actually shot himself in his room and tried to shoot an employee in Detroit. And one incident on here, 2020, where a 41-year-old man in Shreveport shot a pediatric patient's mother and a bystander and then took 3 nurses hostage. A little bit personal for me, so we'll come back to that later and talk about that in a little more detail. Next slide, please. So I think feeling afraid at work is something many of us relate to. I know I certainly have. This is a photo of a resident and an attending at the Louisiana Emergency Department I was working at over Thanksgiving 2020. They were in the room evaluating an inmate who had come in for emergency care. And unfortunately, the inmate noticed that the security guard who had accompanied him had not secured his gun. So he lunged for his gun and had his fingertips on it before the resident and the attending managed to restrain him. So that was seconds away from being a very, very bad day in the emergency department. On the last slide, I mentioned the shooting and hostage situation in the PICU. Same hospital occurred right when I was coming on shift. And again, these are just the incidents that made the news. We were on lockdown for shooter alerts, triaging staff injuries, and dealing with other violence-associated events monthly, if not weekly. Next slide. So please keep in mind, violence is not limited to emergency departments, psychiatric units, or hospitals in high crime areas. Facilities at WVU have seen more than 500 staff injuries from combative patients, making up approximately 8% of total workplace injuries since 2016. And that has racked up more than $1.3 million in associated costs, according to data from our Workmen's Compensation Program. Globally, one 2019 meta-analysis found that healthcare workplace violence was responsible for nearly 62% of workplace injuries in a 12-month period. While it can happen in any setting, the emergency department, along with psychiatric facilities, is more likely to experience assaults. A 2018 survey by the American College of Emergency Physicians found that almost half of the doctors who responded had been attacked at work. 80% had been threatened, and a significant number had also seen patients or others attacked, and that was out of 3,500 physicians that answered the survey. Next slide. During the past decade, workplaces have become more aware of the need for greater security, but is it working? OSHA estimates that being a healthcare worker is now one of the most dangerous professions, with the risk of violence more than 4 times higher than private industry. Even looking at non-fatal injuries, the Bureau of Labor Statistics showed that healthcare workers accounted for 73% of injuries and days off work, and the trend is increasing, as you can see in that graph. The data, which is the most recent available, is from 2018, so before the pandemic, which saw a spike in the number of incidents. Next slide. As an emergency physician, James Sullivan put it, we have to start prioritizing staff safety to the same degree we do patient care. Next slide. So first, we have to define the types of violence that occur, the sources and causes. Violence can be physical or verbal, and it can rise from patients, their visitors, or our coworkers. Next slide. Studies have likewise found causes to be multifactorial. Broadly, risk factors can be categorized into economical, clinical, societal, organizational, and environmental. Next slide. Environmental factors include long wait times, frustration, overcrowding, time of day. For example, for emergency departments, most assaults happen during overnight shifts, a lack of visible security, and the layout of the facility. Next slide. Psychosocial factors on the part of staff also play a role, and that violence is often seen as inevitable. There's nothing we can do about it. And if something does happen, we should be tough enough to not be bothered. That goes along with minimizing the seriousness of an assault and choosing not to report it. And this in turn is exacerbated by the reluctance of healthcare facilities to pursue prosecution. Next slide. So underreporting assaults is a significant part of the problem. According to OSHA, an estimated 88% of injuries in the healthcare workplace are not reported to law enforcement. So if you think back at the graph we saw earlier in those news reports, that's only 12% of what may actually be happening. So multiple surveys of emergency department staff have found that maybe a third reported their attacks, and even then a smaller portion were prosecuted after reporting. Next slide, excuse me. So why the reluctance to report? It's complex, but some of the main factors are feeling like it won't make a difference, having your coworkers label you as weak, having to take time off work to do the report and then participate in any prosecution. And meanwhile, you're risking a poor performance evaluation, retaliation, either by the assailant or your workplace, or a lawsuit. Next slide. But reporting is part of the solution. The impact of a violent incident has ramifications beyond the initial injury. For patients, their care is delayed, whether by the need to start screening everyone entering the facility or by their decision to leave without being evaluated after witnessing an assault. Staff may get distracted by agitation patients, and overall patient satisfaction drops. Next slide.
I do believe that Ms. Lillard had a question.
Okay, sure.
Sorry, I wanted to comment on your, the why not slide here. Part of my role is the statewide forensic clinical director, which is based out of Sharp Hospital, one of our state psychiatric hospitals. And we find the numbers are probably even lower in pressing charges when assaults happen. And the issue that we have run into is that oftentimes law enforcement doesn't want to press charges and states that, well, you knew what you were getting into by working in a psychiatric facility, which can be really frustrating.
Yeah.
I think it's slightly getting better. I know a couple, but it takes it being a really serious assault with a lot of injuries on the staff member in order for it to be taken serious, which is unfortunate.
Yeah, agreed. Why do you think that is? I mean, do you feel like the facility supports pursuing charges and it's more just law enforcement, or is it kind of a combination of both?
I think that it's probably a combination of both. I think the facility would probably support it. I don't know if this is just like, this is the way it's always been, or we know that there's always been, you know, Sharp Hospital is known to have assaults and violent patients. And yeah, it's kind of what I guess it's probably a learned helplessness. Plus, if they do make a report and the police won't take it, then I think that decreases the likelihood of a future one.
Yeah, no, thank you for sharing that. I've run into the hospital not wanting to do it for a lot of reasons, you know, reputation or, you know, again, not taking it seriously. I have not, that's the first time I've heard about law enforcement having that, well, it just goes along with the job attitude, which is unfortunate.
So I wanted to add another comment to that too in the why not column. I actually, in full disclosure, was actually assaulted as a medical student at Sharp Hospital. I was punched in the face by a patient. But I think the other sort of complicating question in psychiatry on the why not list is what's the etiology of the aggression? And that's a real critical one. In my case, it was an extremely psychotic, paranoid patient. And the last, I mean, I reported it and went through the process, but I think the last, you know, it didn't even cross my mind or even consider pressing charges because I knew how ill this person was, and it was not premeditated. I mean, I literally approached her from behind and probably terrified her as much as she terrified me. And so I you know, I learned a lot in that event, but yeah. I think, you know, I think in the moment of fear, you really aren't able to really determine the etiology of those behaviors too. And so I think sometimes understanding the etiology can kind of change a lot of the behaviors people sort of assign to their outcomes is just what I would add. I'm sure you're getting to that, but I think that's
thank you. I appreciate that. I'm so sorry you experienced that. Okay. So we were just talking about the impact on patients, which just overall, you know, results in poorer care for them. You know, for employees, there's also time off work to heal, the development of PTSD, more burnout, increased turnover. And according to a 2023 study of Korean healthcare workers, staff who experienced workplace violence had a higher rate of absenteeism afterwards, and this was exacerbated if their attacker had been a coworker. Next. Thank you. So what can we do to make healthcare safer for workers as well as patients? Well, one of the Stoic philosophers said, control what you can control. Next. Sorry, my slides are out of order. So it can be tricky to evaluate how well the interventions are working. And so in terms of things that we can control, OSHA's guidelines for mitigation focus on 5 areas: commitment on the part of management and staff, worksite analysis, prevention, staff training, and record keeping. So I was able to find one randomized control trial that created an action plan based on those 5 areas that looked at 7 hospitals, 41 units. And the results were mixed. They found that the rate of injuries did not significantly change, although the injuries overall in the US hospitals had gone up. So possibly the intervention corresponded with the plateau in injuries. But other studies have found actually an increase of violence post-intervention, but this may be due to greater awareness and also because people became more willing to report. Next. So what do specific interventions look like? In the hierarchy of controls, a concept I'm borrowing from industrial hygiene, the most effective solution is to eliminate the problem. Unfortunately, that we can't do. However, that still leaves engineering, administrative, and personal controls. Next. For engineering, JCAHO has created a 161-item checklist to identify healthcare facility areas of vulnerability. For example, is the exam room furniture bolted down, Or would someone be able to blockade a door or throw a chair at staff? Are access areas restricted by key cards? Are security guards visible and engaged? Do the security cameras work? Next. In terms of administrative controls, the administration needs to support mitigation measures both by policy and budgeting. According to the Crisis Prevention Institute, as of 2024, only 33% of healthcare organizations surveyed had implemented a dedicated violence prevention action plan. Training should be part of the annual modules. I've never seen a module discussing how to approach workplace violence, like during any of my onboarding training or annual modules, that we all need to do. Has anyone else?
Not that I recall.
Yeah, we talk a lot about, avoiding like fall hazards and, not breaking HIPAA, but we don't talk about workplace violence at all.
That's interesting. I don't,
but not, preventing workplace harassment, but not workplace violence.
Mm-hmm.
Well, it's kind of interesting because I know when I work with trainees, we do spend a lot of time talking, I guess because it's more of a violent situation. Either they're coming to Sharp Hospital or we're going into a jail setting, or the inmates are coming to us here from jail. We're often talking about how do we set up a room? Where do we place the patient? Where do we place ourselves? And why do we do that strategically? I worked in the federal prison system, and we talked about, and I do tell female trainees why I recommend they don't wear a dress or a skirt and why they should wear pants. And so I think at an individual level, maybe in some of these more risky environments, we do go through violence prevention. But yeah, definitely not I don't think at a hospital level.
No, and I love that you guys do that for your trainees. What I would like to see that done for everybody. Because it really can't happen anywhere.
Well, and I would add, they do sometimes label workplace violence and training, but they really do not talk about the severity of some of the physical aggression. They keep it in kind of more low-grade retribution and passive-aggressive behaviors and sort of retaliation, and they call it workplace violence, but they never really advance into those higher risk monitoring to the level that we have. So it's almost like they fake market it to the wrong thing, and sort of underreport some of the more serious things in a way, because at least I feel like we deserve to advance it to the higher levels of risk.
Yeah, that's a great point. Thank you.
Well, and speaking about what's the one called? I'm sorry. What was the slide before this? Engineering. So the one thing that has been talked about by the forensic providers here at Chestnut Ridge is that we don't have panic buttons in our offices. And they stick forensics in this back far corner here. And, there's quite 1, 2, 3, 4, 5, 6. I've got to dial 6 numbers plus the star button in order to get security. And so, those are some other things that I think. Now I know that I think WVU Medicine, UTC, University Town Center, they have some emergency buttons on their panels that they can press. So maybe the newer buildings are getting some more of those kind of security features.
Yeah, and I know in Shreveport, after that incident where the inmate almost got his hand on the gun, we all got little badge alarms, which worked really well, except if you were examining a toddler and the toddler managed to hit it, and then all of a sudden you got 6 officers in the room with you staring at this baby. But they're a great tool to have.
So I was actually a CA in the regular hospital here for a while, and I do remember, because we would sit with patients a lot, that they did have a special training for us to know how to navigate patients that could be physical and would tell you where to be at in the room and stuff like that, because I was resourceful and I often went to Chestnut Ridge too as well. But typically the patients within the hospital setting that we were setting with, they would tend to be more aggressive than like going to Chestnut Ridge.
Yeah. Okay. So in addition, go back one more, sorry. I have a few more things to say on the admin front. Just that, you know, in addition to administration making it clear that they support reporting incidences and pursuing charges, nationally there's some movement. OSHA had their guidelines for prevention published in 2016, and Congress passed a prevention bill in 2021 that included greater penalties for assaults. Next. Okay. And this is how one hospital put these principles into action following an attack. In 2017, a nurse was working alone in emergency department triage at a Massachusetts hospital. She was in an exam room with a single exit when an acutely psychotic patient stabbed her 11 times. So she survived, but not without significant injuries and months of rehabilitation. And in the aftermath, the hospital took a lot of time out to figure out, you know, what went wrong, what they could have done better, and how could they make everybody safer. So next. They made several changes to the facility as well as their processes, as you can see on this slide. They added metal detectors and wands. Now nobody works alone. They increased the number of security officers on each shift. They made sure there's more than one exit from the rooms. They limited visitors. They installed panic buttons like we were just talking about. And they took a very firm stance against threats. They sent no trespass letters to violent patients who had established a record of assault towards staff. And they created an indicator for the electronic medical record to flag patients who had a known violent history. Unfortunately, I couldn't find any data on how this affected their rate of violent incidences or injuries. But I mean, just looking at the list, I think, you know, we can say that the staff felt safer afterwards. Next. So let's switch gears a minute and think about whether we can predict which situations are going to present a higher risk of violence so that we can be proactive before it gets to that point. So next, thank you.
I really appreciate who you said made that quote.
It's a lot of people, but yeah. Okay, so as with the case study we just looked at, there are ways to flag patients as being higher risk and options for keeping repeat offenders out of the facility altogether. So as the last slide pointed out, if you know someone has a history of assault, they've come in before, they've attacked staff, they've made verbal threats, it's a pretty good bet that they will do that again. And it's just something for staff to be more aware of, not to affect their care in any way, but just so staff are a little bit more careful in how they're presenting themselves, how they're interacting with the patient, and, you know, what kind of environment they're putting the patient in. Okay, so part of my research is looking at pre-incident indicators to determine which are actually associated with violent incidences. Some of these include past assaults, like we were just talking about, verbal threats, intoxication, how the patient initially presents to the facility. You know, are they coming in voluntarily, or are they coming in involuntarily? You know, are they in withdrawal? Do they require sedation when they got there? Have they needed to be sedated on prior visits? Just factors like that. Next. There are a number of instruments designed for staff to use to screen patients. Most are designed to be used over time and in inpatient settings that allow for more extensive interviewing than we have in settings such as outpatient clinics or emergency departments. For example, the overt aggression scale is designed to track behaviors over 1-week intervals. Note also that all of these are patient-oriented, whereas we know that visitors and coworkers may also be perpetrators. Next. There's a briefer overt aggression scale for use in the emergency department. There's also a briefer behavioral rating scale that was actually developed by drug companies to assess level of agitation. Next. And this is the Broset violence checklist. I'm not going to go over this in detail. It's more here just so you can see, you know, it's kind of a time-consuming process that would need to be done by each incoming shift. So it's divided into like day, afternoon, evening. It just makes it unwieldy for the way we practice medicine in most settings. So score 0 would correspond to a low risk of violence. A score more than 2 would be a very high risk that calls for proactive prevention. Next. And then an offshoot of the Brosset checklist, the violence aggression assessment is designed to predict the risk of violent behavior within 24 hours. And what I like about this is that it is scaled down, so it's a little bit quicker to do, and it has recommended interventions that go along with each score. So there are interventions if someone scored low, there's different set if they're scored high. Next. And that's what this one looks like. You can see it's a lot briefer than the Brosset checklist that it's based on. But some of the example interventions on this, if someone was assessed as a moderate risk, that would trigger an alert flag in their medical record, as well as a heads up to security and other staff to increase awareness. Someone who scored in the high risk category, interventions could include placing them in a more secluded, calm area rather than the waiting room, notifying all treating staff, and doing reassessments every 30 minutes. But what all of these instruments have in common is that they link types of behaviors. They look at verbal threats, damaging objects, irritability, physical posture. They link those behaviors to acting out violently towards other people. Okay, next. And this is just an example of some of the interventions we were talking about. Okay, next.
Make a comment about,
yes.
Never mind, I think you're gonna get to it. I was just thinking that other measures sounded like quick and easy, but if somebody's agitated and screaming at me, like, I think I already, like, that's my, like, okay, well, they're likely to be aggressive because their outward behavior is showing it. But I feel like what might be helpful is what are the other behaviors, the more subtle or internal stuff going on that might suggest we need to be careful.
Sure. And yes, I think that's what we're about to get to. So this is a tool called STAMP, which is meant for individual providers to rapidly identify and intervene in a potentially dangerous situation. And again, it's based on behavioral observations, but you're looking at stare. Are they making prolonged eye contact, or are they refusing to make any eye contact? Tone of voice. Do they sound angry? Are they raising their volume? Are they anxious? Are they mumbling? Are they pacing? Is that what you were getting at? Okay, awesome.
But just a bit more subtle things.
Yes, yeah. And now I said we were going to talk about the Shreveport PICU shooting again, so we can go back and see whether any of those behaviors were present right before this happened. Next. Okay, so first, the assailant first started arguing loudly with the patient's mother. He then started muttering to himself, pacing, slammed the door to the room. Then he opened the door, left the hospital, went to the parking lot where apparently he had the gun in his car. And then when he came back and staff told him to leave, he pulled the gun out. So I think that pretty much hits every one of those behavioral categories on STAMP. Next. So what do? I think nothing is fail-safe in this situation, but there are ways where you can approach it that increase the likelihood of everybody being able to walk away from it in one piece. So de-escalation training is a tool anyone working in a healthcare setting can use. And the goal is to calm an agitated person through verbal engagement, establishing collaboration, and verbally de-escalating out of the agitation. Next. And this occurs through a verbal loop. You want to listen to what they're saying, validate it, state calmly what you want them to do, listen to their response, and just repeat. And I know sometimes people are like, oh my gosh, this is going to take so long. But there are studies that have shown this can work in as little as 5 minutes. And that's actually less time than it takes to call security and have to either chemically or physically restrain someone. Okay, next. This is a clip of de-escalation in action. I think you guys are probably familiar with the technique. We can play it if you want. It's a little bit long, or we can keep going. It's up to you. And the link's in the PowerPoint if anybody wants to watch it later.
I vote for a little bit of it.
Okay. Yep, go back.
Kelly, we can't hear it.
No.
I think you may have to, there's a setting usually.
Okay. Oh, that's too bad. It's actually a really good clip if anybody wants to watch it after we're done. And let's go ahead and go on to the next slide, please. Did we lose Kelly?
Kelly, can you advance it for her? I think we can't hear it.
Let me see if I can get her through the chat.
I wonder if it's playing into her headphones.
That's why I tried sending her a chat message, so maybe she'll see it, hopefully. I can kind of, I mean, the basic rundown is this is a patient who came in who's agitated, and he's just trying to get him to sit down. And, you know, the patient's reiterating how afraid he is and how nervous he is and how he doesn't want to be there. And he's just doing the verbal loop that we were talking about, where he's, you know, he's acknowledging how the patient is feeling and just repeatedly asking him to have a seat. Okay, there we go. Thank you, Kelly. Okay, so finally, in terms of what we as individual providers can do, this is what I like to think of as the PPE of workplace violence mitigation. So self-awareness and awareness of your surroundings are critical pieces in making our workplace safe for everyone. I think we've probably all been told never let the patient get between you and the exit. That's really important. So is being willing to ask for support if you feel uncomfortable. You have nothing to prove by staying in a dangerous situation without help. Pay attention to your body language, voice volume, and how you're dressed for work. Keep your hair tied back. Don't wear anything around your neck. And if your facility provides them, make sure your badge alarm is working at the start of each shift. Also important, when an attack does happen, debrief afterwards with your team to see what was handled well, what could be improved, and importantly, what resources are available to help everyone manage fear and anxiety in the aftermath. Anybody else? This is kind of a truncated list of things to do. I don't know if anybody has any personal favorites that they want to add.
I would also suggest that not only do you want to keep yourself, not only do you want to keep the path open to the exit for yourself, but you also want to give the patient the opportunity to exit. So we're always kind of trying to make that a triangle so that they don't feel stuck or backed into a corner.
That's a great point. Okay, anybody else?
Now this is from school, because that's where my experience comes from is from schools. But like if they're gonna leave, let them. You know, and so many times I think that in schools, you know, no, they're not allowed. Why are they not allowed to leave? You know, let them leave. And I can see how that would be something in a healthcare setting too, you know, that you feel like you have to get through the triage and the treatment. But if they're gonna leave, then let them leave.
Yeah, absolutely.
Yeah, I would add also, you know, in that verbal de-escalation, when people are telling you they're anxious or they can tell you they need something, respond to reasonable requests. Like people may tell you they're just so hungry or they just can't calm down. You could ask them if something could help, and if they can have it, let them. I mean, sometimes, you know, I mostly saw kids, but sometimes it would be things like, I just don't want to be here alone. I want my stuffed animal or something. I mean, it can be, I mean, they can sometimes verbalize requests in that. And if you can comply with that and allow reasonable requests, because it really, and I'm glad in your stamp you included anxiety. That anxiety response is such a critical factor in the progression to aggression. So anything we can do to mitigate that fear that they're having, or the fear even we're having. So reasonable things that help you manage your anxiety, also massively helpful to decrease the risk.
Yeah, and I think that's a big part of having that kind of collaborative approach versus confrontational. And it's hard. I mean, you know, sometimes it's, you know, 3 o'clock in the morning and you've been slammed by patients and, you know, you don't really want to go get the glass of water. You know, you just want to be able to do your job and help them medically. But I think it helps if you keep in mind that getting that glass of water is part of helping them. Okay, next. Okay. And then last slide. Okay, I think we're slowly adopting the mindset that assaults are not and should not be treated as part of our job as healthcare workers. And I hope this presentation has given you a sense of the scope of healthcare workplace violence and why we need to prioritize mitigation. I also hope that it highlighted that we're not helpless, that there are concrete steps we can take to make everyone safer. And I really appreciate everyone participating in the discussion. And if there's anything else anybody would like to add, please do.
Nice job, Dr. Brundage, especially on it's not a feel-good topic, is it?
No, thank you.
As you know, I've been a physician for over 30 years, and your presentation had me jotting things down on a card, generating memories of past professional experiences and things that my teachers have passed on to me. I don't know who told me it, but it always stuck in my head. You never win an argument with a patient.
That's good. I like that.
Goes back to your point about de-escalation, goes in line with that. And I carried that quote with me, well, to this day, and passed it on to many students and residents that I have taught, that de-escalate. If there's a problem developing, puffing your chest out and proclaiming that you're the one in charge here probably is not going to help. Okay.
Yeah, exactly.
And it increases the risk of something bad happening. So de-escalate. I find myself speaking in a lower and quieter voice when I'm in such situations. I call it my radio voice. To try to soothe the situation. And like you said, don't block the exits. When I was a medical student back in the 80s, a psychiatry resident taught me that. Don't be between the patient and that lone door in that room you're in the emergency department. Make it a triangle so that either of you can run if you need to. I really shouldn't laugh. No laughing matter. I'm sure it varies from state to state, but does anyone know, in the state of West Virginia, is assaulting a healthcare provider a felony? Okay, I know.
I know that it's a special charge. I'll double check the penalty for you.
Although I doubt that crosses the mind of those folks who are guilty of that. This would be a felony, so I'm not going to take a swing at her.
Yeah.
That rational thought process is missing in those moments. And I have a question for Colleen Lillard. Forgive my naivete. Why shouldn't an employee wear a dress?
So to be blunt, it's easier to be raped if you're wearing a dress or a skirt than it is to wear pants. So, I was trying to leave it out because some people get it.
Okay,
sorry. But
I apologize for my naivete. I was like,
that's okay.
What difference does that make? But okay, sorry about that. But
no, but I think you bring up a good point. Like it is I'm pretty I'm just a pretty blunt person, but I make that one pretty clear to trainees. And I know I said, like, I'm not here to scare you, but I just want to make it clear, like, it really does, like, time would matter in that situation. And you're giving yourself some extra time.
Another week.
So that's it for me, Dr. Brundage. And again, thanks and well done.
Thank you. Thank you to everybody that logged in. I appreciate it.
Excellent presentation. I think one of the most important things is talking about it. I still remember my de-escalation training and even how to do a restraint. I mean, it matters to be prepared, even if you don't think you need it. It does also empower you to feel safer in your own way too, to anticipate things and know how to react. So totally wonderful. I wanted to kind of add something that we're seeing as it impacts psychiatry to this discussion, because as people are talking more about workplace violence and trying to be safer, one of the unfortunate consequences, I think, for psychiatric patients that we've seen that is actually probably extending ED stays is we've seen a lot of, especially private hospitals, stop admitting people because of their history of aggression. And I also want to comment that while past behavior does predict future behavior, you always have to be assessing the risks because it can change in a moment too,
Sure.
right? From if it's been treated or not. So it's an ongoing sort of assessment, but we are seeing hospitals refuse to take even, especially kids and some adults that are psychotic because of their risk of violence, not because it's been recent or not, but just saying no. And from a psychiatric perspective, that's really a problem because having a risk of violence is in fact the reason you might need hospitalized for treatment. And so I would envision moving this into those realms to improve specialized units for those patients. But it really is, especially in West Virginia right now, a real problem. I think is increasing some of the violence in the emergency room with longer.
Absolutely. Yeah.
So I guess this is always part of that process of change, is to, build capacity within the system. But I guess I just wondered if you had some thoughts on how we can.
I wish, because I've seen exactly what you're talking about. And, in Shreveport, unfortunately, we didn't even have a separate psych area for juveniles. And they would end up boarding in the ED, along with some of the acutely psychotic adults. And and they could be there for days. And that's the exact opposite of what you want for them. But it seems like a lot of it comes down to budgeting and funding and saying this is a priority, and how you get people to do that when they're not, I'm not sure. I'd hate to, it seems like it takes like a major incident for people to decide to get on board.
I looked up the West Virginia code, so I apologize. Battery on a healthcare worker is the same as battery on a government representative, law enforcement officer, but the first offense is a misdemeanor, 1 month to 12 months in jail. Second offense becomes a felony of 1 to 3, and then third and subsequent are 2 to 5.
Yeah. That's if you can even get to that point in the process. Yeah.
One thing that I wonder about in the prevention of, especially in the ED department, would be how well are those security officers trained for the possibility of psychiatric patients coming in? I mean, I know a lot of police officers, regular law enforcement officers, aren't trained properly in how to distinguish between mental health crisis and true criminal behavior. And they're supposedly paid more, and then you have the security guards at the hospital, which probably aren't paid and probably don't have the same kind of training even that our local law enforcement do. So I can see how that would need to be something really, really hammered down on in order to help increase the overall safety. Because one security guard with I got the badge, therefore attitude is going to mess up your whole ED department.
I think that's where the verbal de-escalation training comes in really handy for them as well. And I've seen there are states that are kind of moving towards a more I'm going to use the word again, collaborative approach to these situations. Like California, there are like police crisis units that now have an embedded mental health professional, which I think is fantastic. I wish we could do that everywhere. And I wish we could do it in the emergency departments, because I think that would probably help also. So yeah, from what I've seen anyway, I agree completely. They don't seem to have specific training to approach those situations maybe a little bit differently than they would on their regular duties.
Yeah, and I think Teresa highlights like a really important point is that, you know, you have to, there's also, you have to be safe, but you also have to then move very quickly to assessing the etiology of how to treat it, right? And that if you don't, if you can't tell if someone's psychotic or this is a meth-induced, you know, aggressive episode, you can't move quickly to mitigate the true risk. I mean, you can have someone that's floridly psychotic, pulling on restraints and punching, and it doesn't matter. They're just really, they need drugs, or they're not going to recover, you know, and so, you know, and I think, you know, so it has to be collaborative, because you have to keep it safe, but you have to rapidly move from safety to finding out that etiology, because, you know, and some etiologies are things like the positive behavior support. You have to move into other treatments that might not even appear medical. They may be more therapeutic sort of modalities to decrease that risk. And so it takes a village, absolutely. But you can't do, I mean, I said, you can't do anything. It's kind of like never argue with the patient. You can't make any good decisions that are fear-based if you don't feel safe to move rapidly into that. And so it really has to be really a culture shift, a culture change of facilities, providers, and the entire environment.
Exactly.
All right. Does anyone else have anything they'd like to add? All right.
I just really want to thank you for coming to our Echo. This was really wonderful. Really enjoyed your perspective. We really loved having you as a guest.
Thank you. This is my favorite Echo, so I was very excited to get the chance to do this. And like you said, nobody talks about this much. So I was like, oh, good. And I really appreciate the interactive discussions. That was great.
Yeah, this was wonderful. It made me think about I'm in the psychology training program, made me think about maybe we need to formalize a didactic about workplace violence for them. So
see, that would be wonderful. Yeah. All right. Enjoy the rest of your day. Thank you.
All right. Thank you so much, Dr. Brunage, for joining us today. And thank you everyone for your participation. I want to go ahead and remind everyone that we're not meeting again until July 3rd. And that will be on impacts of childhood neglect and abuse by Kelly Kusner. So we'll see you all then.
Thanks for your help, Kelly. I appreciate it.
Oh, thank you. And sorry that
no, that's
I couldn't hear anything.
I know. I mean, it must be something about